So I'd like to introduce 3 ways of doing the treatment with ácido hialurónico, hilos, o los dos, combinación, ¿vale? Of the nasal bone, the frontal process maxilla, the septal cartilage, and the crus cartilage, the lateral and the medial. When we're doing filler in the frontal area, fine. But with the nasal arteries, all of these main branches are on the lateral aspect of the nose. And so we concentrate our treatments with threads and with the ácido hialurónico down the middle, away from the major arteries and away from the major branches of the artery. Always we pull back on the plunger before injecting the bolus as normal. And if we avoid treating the side of the nose, the chances of a vascular event practically 0. So all my injections will be on the back of the nasal bone or the nasal cartilage, or downwards between the medial crus cartilage. One problem mainly is if your patient has had surgery or trauma before, and there can be a change in the vascular anatomy, which is when I prefer sometimes to include more threads, because you cannot cause the occlusion with the thread. This is the approach of a very experienced doctor in the UK, and he uses a 4-point strategy. So he likes to treat first in the radix with bolus ácido hialurónico M4+ for the elevation. His second injection is usually at the base to stabilize the septum, and thirdly for the tip or elongation. And then finally he likes to do the super trip with bolus, small bolus, 0.05, 0.01 injections to straighten. I like a different technique, which I want to explain. I like to do his 0.1 at the same. So I will start with the radix, and then I address points 2 and 3 with a cannula from one point on the tip of the nose, going directly down, perpendicularly down to the maxilla between the crus, and to inject after lifting into the position with your non-injecting hand. I will place the cannula directly down as far as the maxilla, and the beauty of the cannula, which is why we did ask earlier, is that they have little lines at every 10 millimeters, at every centimeter, so you can judge the depths of where you're at down to the bone. With the M4, if you stop halfway, it will not migrate, it will stay there and lift. They say this angle between the nasofrontal angle in a female, they say 110, and this angle between 90. So the normal ratio, the length to the height, 2 to 1, length to height, and Caucasian width to height, 1 to 1. Lots of patient concerns, and for me 3 treatment options: hilos de ácido hialurónico or ácido hialurónico. So toxin for the tip, it can help, but it's short acting. The average treatment with ácido hialurónico or threads, the first treatment, 15-18 months. Toxina, solo 2-3 meses aquí. So for this lady, who I will do as number 1, I've just seen her. So first, we need to address just above the dorsal hump. Secondly, I'm going to lift the tip. I don't want to elongate too much. So 1 with filler, 2 with filler and cannula, as we said, from a point just behind on the tip of the nose down directly, and inject as much as we need in retrograde fashion, stopping at mid cartilage. From an arterial vascular concern, I'm not concerned about any vessels here in the midline. Here people are concerned about the septal vessel, but my treatment, by holding with the non-injecting hand and elevating, separate the space from your septal artery. Theoretically, we talked about arterial compression. I've never read a case in this area of compression because of the amount of mobility and space in this area. And then from when I saw the lady, I will like to introduce from the same point a thread, she has slight deviation to the right, and I would like to try and straighten this side with 1 or 2 threads. So we show you how we do this as well, because I don't want to inject any filler on the sides of the nose because of the blood vessels. I'm I'm worried too. Okay, on we go. What do you not like with your nose?
She doesn't like the basal of the nose, and at the same time that is really elongated, okay, but in a bad way. And at the same time, she's afraid that the treatment will make her nostrils look wide or wide open.
What I think first is, as before, point 1, we will treat in the rhinion with some vertical deposits down onto the bone. First, we will treat with vertical deposits onto the bone, okay? All injections onto the bone or onto the cartilage, deep, okay? Secondly, I will then, with the cannula, make one little point here and place the cannula down to the maxilla, okay? By stretching first, I will hold the columna vela and lift, stretch and lift to get the tip into a position that we would like. Then with the cannula directly down from the tip to the maxilla, and I will use that cannula while it's down attached to the syringe to gauge the depth, and then by injecting slowly in a retrograde fashion, stopping at medial cartilage crus, okay, and we will deposit enough to hold the nose in that position. If it's 0.5, if it's 0.4, if it's 0.6, in most studies with this technique, in Asian patients, it's more than 0.7, it's 0.71, okay? In Caucasians, it's more 0.65. So it tends to be slightly different to alter the tip. When we've corrected the tip, we may then need to put a few deposits, again, vertically, in the midline, onto the cartilage, okay? And then my final thought, when I looked earlier, would be just to give a slight straightening of the nose to the left by using a thread, okay? They have 2 nasal threads, a 38 millimeter, which is for elevation of the tip, which goes down. Okay, now if you think 38 millimeter, the length of the cannula with the thread is 50. So this is one reason here, the normal needle for hyaluronic acid with 13 millimeter, for me, is not going to allow me to get deep enough, and you would have to inject bolus from below and the bolus from above. So I like minimal pain, minimal trauma. I'm a baby. And so with one entry point, I can do that with the one injection. I always like, when I'm doing toxin or anything as well, I tend to inject and look first from behind, because you can see more and the symmetry from here. So I see just ever so slightly from here, a little depression here and here, but I would prefer with threads in this area for the safety perspective. This is where I'm going to start with vertical injections of M4. I'm then going to just put one little anesthetic tip here, make a puncture, and I will go down with the cannula, holding the nose, up, down, okay, to the bone, to get a gauge of the depth, and start then to inject slowly on a retrograde fashion, and stopping at mid cartilage. So I just like to mark just where we're here, the top of the hump, and the most inferior I will go with the filler. I like just to pinch to separate again. Vertical.
Separa, vertical.
That's onto the bone.
Llega al hueso.
Little pullback, and then I'm just going to inject at the M4 0.05 mils.
0.05.
Yep, come out. And then my last one, 0.05 onto the bone. Slowly stop. Out. You can inject from behind. It's not a problem. You know, it's where you're comfortable. I like normally from behind as well because the patient doesn't see this. I'm thinking one more just here. So again, midline, deep. For the nose, I only use Intraline M4. Okay. It gives projection, it lifts, it lasts, and it stays where it's put. So for me, it ticks all the boxes. I would just like to strengthen the lateral, the edges of the dorsum, almost like defining, okay? Like a little bit of structure, as you were saying. You could do this at the beginning. Now I'm looking, and I like to do it just now. So I'm just looking, and I want to put a little bit of strength with the threads here. So using the same point that I did with the cannula, I've just got lidocaine, and I've used it. I'm just going to go now.
Para mejorar el confort de la zona a tratar, él va a colocar el mismo punto de entrada de la cánula anterior y va a colocar lidocaína en la área dorsal para poder introducir. And I'm just going to very slowly infiltrate with tiny aliquots, little. A medida que va introduciendo la cánula, va colocando microbolus de very, very small. One gentle little puncture, which again, okay, bien. Secures the cogs, skin up, so facing the skin. And then just gently advance along the tip. This is here. And holding the nose now, just to remove and hold. Okay. Dorsal nasal. Por lo tanto, no tienen que utilizar ni tijera ni ninguna otra material que deba cortar el hilo. Okay. So this thread now is the whole length of the nose. We can hold it, remove, and just hold the tip. What I would say is this is enough. I will remove the drawing. And if sometimes, as you said, maybe in a younger patient or where there's not so much of a hump, if you just want to get a little bit of a direction, you can treat one side, or 2, 1. You can structure to make it appear thinner by just using threads, maybe 5, along the lateral, medial, and in between, and that will cause a little bit of structure, pinching if you want, in a broader nose to make it appear thinner, plus lifting the tip. So I just finished this. So it's possible if you just wanted with a broader nose to make it look thinner from the same point, we can use one thread here, one thread here, one down the middle, one in between, so maybe 5 in a little sharpening, like a triangle for structure, because those threads will last 6-8 months, and as they are broken down, because they will be, into water and carbon dioxide, your body will replace it with collagen, and the effect lasts
18 months, 24 years. So with the filler alone, 18 months, very common. With filler and threads, the same. And I think all the different techniques will give up to 18 months. With the threads, it's important that if you do use the threads, that you insert the whole length of the thread. Hold the tip when taking out the cannula, because it's not like the cog threads that you may use for lift where you pull and cut. The whole of this thread stays inside, so you can't cut it. Okay, if you want to use a shorter one, maybe on a short nose we have the 38, 50, but normally those are for the lifting of the tip. So I think the only thing she felt was where the cannula hit the top. So when you go to the maxilla, when you go to the maxilla, and you can just, even if you slow, you can feel, you know it's going to happen. You just touch the periosteum. It's not as painful as with a needle, but you know, and you can see the patient go, try to be brave, but the eyes give it. Vale, gracias.
Muchas gracias.
So the M3 is what we're seeing today. The M4 specifically for the nose. It is why it's so good. But we essentially have a range of 3 products that gives you a nice rheological profile, which is good for about 90% of the treatments that you'll have to do in your own clinic. We did a study. It was a small rheological comparison. Comparing some of the top brands. So the M2 from a rheological standpoint is closest to the Redensity 2, and then the M3 is superior to Ultra 4 in terms of thickness, and then the M4, which we're using today, is comparable to the RHA4. So it gives you a nice profile, and you can feel confident in switching. We actually don't recommend the M2, even though the rheology is similar, because it's more cohesive. We actually have something called Intraline 1, which is biphasic. So the fillers are designed actually, even though the rich viscoelasticity profile, they're actually designed to be easy to inject. So they're, not like water, but they inject easier than you think they would. But once they're in, they stay in place. Cohesivity, the migration is very low in these products.
So first, from behind, the line is quite good. Okay, there's not possibly tiny bit. Again, we're talking about treating the rhinion for the angle and and I see the height of the hump here. So we will start again with the bolus hyaluronic acid down onto the bone. Then there is a little super tip depression, but I'm going to first try and lift and elongate the tip by doing our cannula perpendicularly again, and then finish, because that will lift, and then we'll finish with a bit more filler in the super tip. Injection point 1 from our first slide. Then we got to use the cannula, although on the other slide we called it point 2 and point 3. I use the cannula for the combination, and then finally we'll do point 4, the super tip. So just tiny pinprick.
You're going to start with the cannula?
Nope.
Oh,
I'm just going to let that go numb for a second. Just going to be nice. And then 27. So again, 27 needle. Okay.
Utiliza aguja de 27G.
Gentle separation.
Retrae un poco la piel e inserta la aguja hasta llegar a hueso. Zona periósteo.
0.1.
Coloca 0.1.
0.1.
Otra vez 0.1.
And finally, yep, 0.05.
0.1.
That was 0.05. Yeah. Possibly again 0.05. Perfect. Cannula. Resistance gone.
Punto máximo en la punta nasal.
Yeah, looks good already. So now I pick up the columnar.
Trae la piel. Respira hondo. Vas a sentir una presión a nivel bajo.
Bien.
Nivel.
Bien.
Eso. Perfecto.
Y ahora
Respira hondo. Muy bien. Abre la boquita y respira por la boca. Eso, muy bien. Coloca un microbolus en la base y luego posteriormente el retrotrasante va colocando hasta la mitad del cartílago. Recuerden.
and I can feel it filling.
Poco a poco sentirás cómo se va llenando el ácido hialurónico, se está dispersando o depositando en la zona a tratar.
Okay. And now just a little.
The Tinkerbell.
Like the tip up. Okay.
Respira hondo, prontito. How much are you you're using to put there?
That was 0.1.
0.2, 0.1 y 0.1.
Aquí 0.06.
6.
See, I'm thinking 2 threads.
Quiere decir que la jiba está generando algo que se puede dejar así, pero que puede mejorar más la armonización de esa nariz. Lo está considerando.
See, the only thing I'm looking at is a little depression here. And so I was looking and I'm thinking it's scarring.
Mm-hmm.
And it's being held. And so I'm thinking, because of what we said about the blood vessels and previous trauma and scarring addressing, do I maybe use a thread? Because if I use a thread as well, it can subsize the scar that's holding down to also lift the scar.
Vale.
So I'm thinking that we just do now 2 threads to structure and help maybe subsize this. So now I'm just going to put a little anesthetic, lidocaine with the cannula again. Okay. So now I just trickle a little lidocaine. Perfect. So good. Thread up. Okay. Thread upwards. Perfect.
Respira hondo. Una presión.
Bien.
Respira. Aguanta
Perfecto.
un poquito. Perfecto.
Is okay?
¿Estás bien? Ok. Perfecto.
Okay. 2. Lift. Stretch. Bien. Perfecto. Finito. Listo. Down both sides. So the one is down here and it's lifted the scarring where I think was before the depression here. was bigger. Now it will lift it straight. So this little swelling is a tiny bruise, but now if we watch the screen and then what I said about the pressure and seeing how quickly the color comes back, if I put my finger on there and you watch the screen, and the minute I let go, the perfusion comes back. Yeah, you can do it everywhere. If you want to check it, comes back. Here, straight away, you see it, the blanching go. There's not going to be any vascular risk with that. You can, that's, the problem would be if you did something like this, you take your finger off and it's still pale now, then that's slow. So I think when I look here now, we both saw before, so there's a little bit of swelling here and here, and this will all settle down. And definitely now I see where we put the thread in, that that little scar depression is elevated more. Often if you use the threads for lifting here as well, I'll use a mixture of HA and PRF into the subdermal, and then the threads go through beautifully, less painfully, and they will still attach. So it actually tends to be a little bit less painful as well with the filler. Gracias. Normally, this slight touch compression, so if it's arterial, usually very quick, it's immediate. You see a bluish discoloration, huey color, a huish color blue, or pale, and it's quite large, unexpected large and quick. More pain than you would expect. Sometimes the color you blanch with your finger, and you take your finger off and it will remain blanched for quite some time. And you must use hyaluronidase, Hyalase straight away. So sometimes the initial stage is just excessive redness or bruising. And if this is left and not treated, so there are lots of different protocols, but in the notes that you have, we'll have a copy of this protocol. And one of the things is that if you want to dissolve a treatment, a normal treatment, it is suggested that you do an allergy test with Hyalase. You will get a reaction with Hyalase anyway because it causes histamine release. So hyaluronidase will often, if you do a test, look like it's an allergy because you will get histamine release. In an emergency situation like the previous slides, forget allergy test. Use it, observe, and repeat until you see the circulation improve. We dissolve the one vial, 1500 units. So in each 0.1 mil, there is 150 units. So one of these syringes for the whole Hyalase, and then we inject 0.1 direct into the area where you injected the filler. Reassess after a few minutes, and if there's still slowness of the capillary refill, repeat. Okay.